we talk about immunity, I want you to be a part as an interactive lecture. This lecture will go back several steps that we started with. And you are going to refresh me from what we know about. When we talk about immunodeficiency, what does it mean? Immunodeficiency, tell me. Be interactive. What does immunodeficiency means? Come on, guy. What does immunodeficiency? Speak out. Don't be ashamed. Probably.
The immune system cannot fight foreign.
Anybody else? Immunodeficiency basically is a person has got deficiency in the functioning cells of the body. These functioning cells can be of myeloid lineage and lymphoid lineage. They can be non-specific deficiencies, especially involve the neutrophils, the phagocytic cells, or it can be T cells or B cells, which means they can also be combined. So basically the deficiencies can lie with one set of cells, and it can lie with the second set of cells, or it can be completely combined together with both the effect of the myeloid, non-specific as well as specific immunodeficiencies. Now, questions is, there are many types of deficiencies, but many types of deficiencies does not mean a person is immunocompromised. A person may be immunocompromised because of certain outside elements, which I'll come to because you have another lecture on immunocompromised hosts. Immunodeficiencies can be achieved in two ways. Immunodeficiencies can be inherited, it can be genetic, all right? Or what is inherited? Inherited from our parents, all right? Or there has been some problem in the actual development of these cells in the body. Originally, when we were still not born, so there was a fetal problem somehow through which we have been unable to develop these as a full-fledged immune cells. All right? Now, the question here is, in many of these circumstances, when the immunodeficiency shows itself, it shows itself a bit later on. It's not that the child is born immediately and you will expect these immune cells to function. It does take time when the infection starts coming to this patient, and then you realize that there is deficiency somewhere as it is. I have talked to you about Omen syndrome. I have talked to you about Omen syndrome, about a child who died, don't do that, about a child who died at the age of 9 years. I told you about this child, which I published as a paper, was that his neutrophils and phagocytic cells were not functional, that he was getting recurrent skin infections, tissue infections, and every time you treat it by antibiotics and other things. Yet he kept on getting these infections, which was recurrent infection, till a time came that the child cannot fight this infection. It doesn't mean that T and B cells were involved. It only means that the phagocytic cell were unable to present this cell to the T helper cells, to process it, produce antibodies, have T cells come and fight these infections. So when the phagocytic cells or macrophages, which are also dendritic cells, remember dendritic cells, they are all antigen presenting cells. If they do not present the antigen to our specific cells, then obviously there is a problem. That part of the immune response will not carry forward. So this was one of the things that one has to take into account. The other thing is that usually these infections comes in the where? Open spaces, in the skin, in the oral cavity, in the vagina, in many other locations which are exposed. One of the infection that can show that a person or a child is getting an infection is Candida infection. I gave you a PBL on nappy rashes and Candida infection. It does not mean that all the children who have Candida infections or already have got a defective immune response. But when it comes recurrent, remember that immunodeficiency, when it's a recurrent infection, then obviously your mind goes out that there is something wrong with these infections. Now what cells are involved in Candida? T cells. T cells is a potent immune cells that can fight off Candida. So now the question here was that the symptoms in the patient will show by itself. If somebody has infection of the skin, it does not mean the person has infection inside. It does not mean that some other cells which are not responsible for these skin infections are also involved. What are the circumstances when most of the immune cells fail? The first part is HIV infection. HIV infection affects the T helper cells. T helper cells which actually process the antigen, presents it to the B cells to produce antibodies, which are HIV antibodies. It also has T cells because it's a viral infection, so they want to kill it off. But when the T helper cells is overwhelmed by these viruses, and the load of virus goes up, and the response of the T helper cells goes down, then obviously there is a problem. And this is what happens in T cell involvement, especially with HIV infections. Does it mean the patient cannot fight off infection of the skin? Well, they can fight off infection of the skin. But what happens when HIV infection reaches its peak? The patient develops AIDS. And these are basically infections that the patient cannot overcome, and they die because of those infections. These are called opportunistic infection, which only invade patients who have subdued, suppressed immune response. The other one is maybe a transitory factor, can also be a person can have severe radiation problem, such as those nuclear power stations in Japan and other places, because the total cells of the immune system are non-functional and they will die eventually with high radiation. People who had certain chemical association can also have the same thing. Sometimes we take drugs to immunosuppress some of the reactions that we have. But we don't give, and you clinicians won't be giving lethal doses of steroids and other places. You will give only what is required, and for a shorter period of time. Why you do that? Because you don't want any outward reactions to happen with the immune system. So that's why you suppress some of the cell functions, which can be actually reversed back to its original form. So basically, if you divide that, immunodeficiency is basically a failure. It's a failure of the cells, a failure of the immune system, failure of the immune responses that we have. And as I say, this immunodeficiency or loss of function of these cells will actually can lead to many diseases, including malignancies. All right? So this is an important factor. As I told you, primary immunodeficiency can be present at birth, but it may come out later in life. So when a child is born, you would not know. And this can be because of genetic or development stage during the fetal development stage. All right? Now I give you one example, which I will come back. Your T cells, we say early on, matures in the thymus, correct? So thymus is the organ which has different pouches, pharyngeal pouches. So it goes from 1, 2, 3, whatever it is, and matures at a different stage. If there is a defect in the thymus and the maturation process is not attained, then obviously the person will have T cell immunodeficiency, because that particular organ has failed to mature the T cells. This is also called the George's syndrome. Okay? Is basically a defect or immunodeficiencies of the immune system, especially the T cells. Now, as you can see, secondary or acquired immunodeficiency is again the loss of immune function, and there are different disease agents such as HIV, I told you, environmental factors can, immunosuppression, and sometimes aging. Now why we say aging? Why we say aging? You see, if you look at old people, they are vulnerable to many diseases, many infections. That's the way things go on. Their immune system is not as robust as what you think. Similarly, if you take a long-term sick patient who comes out of his sickness from the hospitals or anywhere, whether they are patients or our relatives, they require certain amount of boost up to their immune system. What do we do with old people? What do we do with these sick people who have come out of the hospital? We try to give them high protein diet, soya milk, this, that, etc., which is highly protein. Protein diet is an essential nutrient for the maturation and actually the advancement of these immune cells and their functions. So that's why we give them high protein diets. All right? Now, let's look at some of the primary immunodeficiency. I've told you they can be non-specific or a specific immune response. Okay? They can always be defined by you as clinicians, whether it's an outside involvement, whether it is an inside involvement, whether it is a viral infection which attacks our other cells in the system, whether it is a Staph aureus, a pus-forming bacteria which infects our skin, whether it is a candida infection which is affecting us. So when you are looking at this patient and you see not one-time infection can come and go. But if the same patient has recurrent infections, you immediately will say, look, this patient has more candida infection, more recurrent infection, more Staph aureus on the skin, so obviously there is something wrong. If the patient has, I'm just giving an example, a patient has viral infections, and they have several viral infections coming and going, then there must be something wrong. So what would you do in your capacity is to look and classify these lesions or the site of these lesions, okay, and based it on your immune cells or immune system. Is it non-specific? Is it specific? All right? So these are things that you would do. Now, let me take you to a clinical room, and you are an attending physician, and you have a patient coming to you, and the patient you see both ways, non-specific, specific, or either of them, or complete, both of them, is called a secondary responses, and it's combined. What would you do if someone has an infection of the skin or recurrent infections of the skin? What would you do? What would you do? Come on. Huh? What would you do, my friends? No? Maybe it's not that contagious. So what would you do? Simple thing is, test it in the laboratory. Are the levels of these cells okay, or they are deficient? If you look at low neutrophil counts, low macrophage counts, obviously there is some defect. The other problem is, go and introduce these phagocytic cells in a culture dish and put some microbes in there and see whether the phagocytic function happens or not. So if they are, it is possible that they may have the phagocytic cells, they may have the neutrophils, but they cannot function properly. So that's a functional difficulty that the patient has, which had happened in the Omen syndrome that I talked to you about, this boy. All right? So these are some of the tests that you will do. The other one is, again, recurrent infections which are of a specific type. You check for T cells, you check for B cells. What's the other test that you would do to say that this person is protected? What? Let me see how intelligent you are. I know you are intelligent, but you need a little pickup. What do you do? What would you do?
Antibody level.
Absolutely, my friend. Antibody level. Who said that? Antibody level against the immunized patients. If I was immunized with measles, mumps, rubella, chickenpox, polio, whatever it is, I must have those antibodies. If I don't have those antibodies, it really points to no response of the B cells, which means that our B cells are not working. Similarly, what you can do is, before you take out the blood, you say, look, I'm going to do a skin test for you. And I want to introduce some antigen or mitogen, non-harmful one, into the skin. Okay? So you take, as you do for BCGs and other things, you take this mitogen, inject it under the skin. Wait for 36 hours. If in 36 hours this becomes flared, red, hot, little painful, you will say the T cells are working there. They are functional. So many of these different tests are there for you to actually see what is wrong with that. What are you looking at? Huh? What's that you have in your hand? Don't do that. So a person can be susceptible to many different types of infections. All right? Now look at this. For a simple reason, if you look at the defects in the non-specific immunity of phagocytic cells, you'll see that there is no neutropenia. Okay? What would you see? If you look at the neutrophil function, you can look at if there is a complement deficiency somewhere which is not contributing to the chemotaxis, to the attraction, to the lysis and the killing of these microbes. That's what you would look at. These are the main ingredients if you have a skin infection, correct? Now, one more thing. We all have certain amount of antibodies or immunoglobulins, natural antibodies. So if I measure your immunoglobulins, my immunoglobulins, we have certain amount levels of these immunoglobulins. If we have vaccination, we have a specific type of immunoglobulins, which means IgG, which is the main predominant one, will have measles antibodies, polio antibodies. But now let me tell you one thing. A person, if you are sitting and order a laboratory, I want to know the immunoglobulins level on this patient, and they send you IgA is this much, IgM is this much, IgG is this much, etc., etc. You'll think, oh, they all look normal to me. They all look normal. So where is the problem? My friend, there's a problem there. Why? When you see this and you still see the infection, we should have actually consumed some immunoglobulins, raised some immunoglobulins. It's not doing this, then what you would say is there are subunits, sub-regions, sub-immunoglobulins like IgG1, 2, 3, same thing with IgA. So then you tell the laboratory, well, can you break up the IgG and tell me what these different sub-immunoglobulins look like? And when you look at this, you will see IgG1 is low, deficient. IgG2, 3, 4 is fine. So where does your mind go? It says, because IgG1 is low and it is giving viral infections or recurrent viral infections, it is the immunoglobulins which is not produced for that subclass. But what can you do in these circumstances? Maybe possibly you infuse some immunoglobulins, normal immunoglobulins in the patient. But that's not a long-term treatment. So some of these immunodeficiencies earlier on can show you like this, but they may recover. They may be reversed at a later stage. And when they reverse, they may come back to normal. So it can happen even in the development stage at a later stage of life. It can be reversed. Maybe some other cause has caused this. So that can be reversed. Now, one of the things, defect in non-specific immunity, is chronic granulomatous disease. What is a granulomatous disease? Okay? Come on. Without looking at that, tell me. Granulomas. You have phagocytic cells, you have particles. These particles should be eliminated by the phagocytic cells, correct? But what happens is, they start accumulating as granulomas, as clot-type granulomas. They will settle in the lymph nodes. They cannot be processed. Why? If you look granulomas, it can happen anywhere. That's the swelling, the inflammation of the condition. So then you will say, fine. The problem here is that the phagocytic cell is not doing its work, is not actually having a respiratory burst for O2. I told you when phagocyte cells do activate, they need glucose and oxygen. And that may be that they are not oxidizing these oxygen, and hence the phagocytic burst is not happening. So the organism is accumulating, yet it's not being destroyed. All right? That is called a granulomatous disease. There can be also a chronic form which can remain, and I've seen a child who has this problem, who is next door to where I live now. Okay, I think he's a Tunisian guy or Algerian guy, a boy of this who's getting too much of granulomas. He's under treatment. It's not been improved. Sometimes when these granulomas form, he's walking with difficulty. And so is it curable? Probably not. But it is very possible that you can give new sets of cells, the stem cells, to propagate any missing cells that are defective in the immune system. The other one is, as I showed you in the picture, I showed you phagocytic cells moving around, a live picture, how it grabs with the pseudopaths, how it takes in. Didn't I show you this? The question here is, there is a dye test called NBT, nitro blue tetrazoleum test. What happens is that this is a blue dye, okay? And when you introduce it into a culture with the neutrophils and some mitogen or antigen, you would feed that these oxidative bursts are such that if they are functional, the whole thing will become yellow. Okay? Before it was a blue dye, it's become yellow. So you can see it is functional. So there are laboratory methods that you can use to actually. Walaikum assalam.
Just one quick point.
Yeah.
Guys, the meeting with director is next week, okay? Send your leader to me after the lecture. Not today, okay?
Thank you, sir. I deserve a coffee. We call sir, each other sir, with respect. He's a good colleague of mine. Now, the other point is, even with the primary immunodeficiencies that we are talking about, we have B cell antibody deficiencies. It's also called common variable immunodeficiency. What does it mean with common variable? Come on. He's recording me on the camera. What is a common variable? That means any aspect or any immunoglobulin levels can have variable limits, correct? It may be functional, not functional, some may be functional, the others may be not functional. So basically it goes around the range as a common variable immunodeficiency, okay? I may have a good IgA system. I may not have a good IgG system, all right? I may not have complement. I have a deficiency with a complement. But again, for any immune system to work, you need a cooperation between the different cells. Without that, it cannot happen. So it's very important from that. The T cell-mediated immunity is also called, I told you, it doesn't mature in the thymus properly, known as the Georges syndrome, and a lot of viral infections which we know that T cells will kill cannot be actually achieved. You have a B and T cell combined, which is called severe combined immunodeficiency, SCID. You had this with the bubble boy syndrome I gave you. I select these from your topics to give you one of the best cases that we have. You only did a brainstorming on that one, correct? I told you those people require transplant, stem cell transplants. They cannot be achieved unless they are meshed, or they have new stem cells which are not mature. Okay? So that's the boy who is waiting for this transplant. During that time, because none of his cells are working, he is prone to many infections. That's why you keep him in a bubbles. Not even the father, mother can touch him. So he is protected from outside infection till he receives a stem cell transplantation. Now, the common variable immunodeficiency which I was talking to you about, let's deal with it. You can have any number of these as low IgG, low IgM, low IgA, not up to your expectations, and that is called pan-hypogammaglobulinemia. Okay? So you must know that. You can have low antibodies, though you may have B cells and T cells numbers are normal. It is very possible that because you require antibodies, because you require IgG, some of the T cell functions may be impaired because you don't have the immunoglobulins which are required to fight these infections. As I said, all the immune cells are interconnected. They have to cooperate with them. Any missing link is a problem, and that problem affects. So common variable deficiency can happen between 15 to 35 years, males and females, and they can get a lot of diarrheas, pyogenic infections, pneumonia, herpes, autoimmune diseases. So there are many different diseases a patient may go through. There may be a selective IgA deficiency. Why is IgA important? It's a secretory IgA. It's in the mucosal surfaces, correct? We require it. So what will happen is either they are low or absent. So mucosal secretion does not have IgA, which can destroy the organisms. But you can see both the B cells are normal. Usually recurrent infections, allergies, autoimmune disorders can follow if IgA level is low or absent. So to fight infection in the mucosal surfaces, we have certain bactericidal enzymes, lysozymes, and so on. We also have ciliary movement. We also have IgA, which can kill off those infections. Okay? So remember, IgA will play a part in the mucosal surfaces only. Now, I'm not going to go into this, how you would do this. I have told you that how would you test for T cells. One portion of the T cells was the skin. Okay? The other portion of the skin is you do a mixed lymphocyte culture. It should be MLR. It's my mistake in the slide. and also PHA. What a phytohematoglutinin? Phytohematoglutinin is a mitogen. It's a mitogen. It's not an antigen. It's not active. Though this is from lentils, you know the lentils, we take lentil soup and this and that. You know the yellow lentils that we have, or reddish or pinkish, and you cook it and make nice soup about that. Well, this is something which is extracted from there. This has the potential of stimulating the T cells. So now I'll take your peripheral blood, I'll separate your T cells, B cells, and I put it in a culture and put some PHA on that. When I put PHA, it's a foreign material, it will react, it will become blast cells. I showed you my stem cell technology, how they become blast cells, and millions of cells will be produced. All right? So PHA stimulates the T cells. If it doesn't, there's a defect. MLR is mixed lymphocyte reaction. If I take your lymphocyte, I take my lymphocyte, mix it together, I irradiate X-ray my cell so that it doesn't proliferate. So when it proliferates, it will be your cell acting against my antigen, which are fine. And vice versa, you can do that. So that is also a way of actually evaluating the actual responses in cell-mediated immunity. Now what do? You don't go and take out you don't go and take thymic transplants and take out a thymus and give it to somebody. That thymus is lost in the person. It's not like two kidneys as you do, take one kidney out, one is still surviving. So you would not do that. But if you put a new thymus, because the thymus is not maturing the T cells, then obviously that's a big deal. So you say, okay, fine, khali wali, no problem. Let the person mature a little bit, and his T cells will mature as it is in the bone marrow. We may not need the thymus to mature it, all right? And these recurrent infections will happen because there is a problem, and this is called DeGeorge syndrome. It doesn't actually. So there may be Candida infection, again, chronic mucocutaneous candidiasis can happen, and it can happen within a children. Again, CMI, cell-mediated immunity, is a defect, which I told you, T cell function. T cells is important for Candida, and it doesn't finish the Candida. You keep on treating it with anti-Candida drug, but it still keeps on coming, which means the T cells are not functional. Correct? So this is what happens. The problem here with the secondary acquired, now we were talking about primary so far. Now let's come to secondary. Secondary can be reversible. Why? If you look at some African countries, if you look at Nigeria, there are children who are starving. Soon you will see people in Syria and other places will be starving. When they are starving, they are not getting the nutrition or the protein to pump up their immune system, immune cells. But once you give them, so starvation, and people who drink a lot of alcohol. So now people with a starvation, if you give them good diet, high protein diet, including the aging people, including the patients who have long-term history of being in hospital, coming back home, give them a high protein diet, you try to boost up the immune system. So that is reversible. They will get infections, Epstein-Barr infections, HIV, as you can see in the secondary. Drugs like corticosteroids, cytotoxic drugs also may have an effect, may be overridden by some reasons, okay, reversible by some reasons. But there are malignant diseases can happen, especially in the secondary acquired immunodeficiency, lymphoma, leukemia, myeloma, and this is very important because there is some mutation in the cells are happening. So the cells are not functional. So the cancer takes in, the lymphoma takes in, malignancy takes in, all right? Because it cannot kill off those cells, and it has mutated to some extent. Aging, I have already told you this. Now, one thing is very important. In certain individuals who have recurrent diarrheas, you say, fine, look, I'm going to keep him hydrated rather than dehydrated, fine. But the question is, the amount of protein you give to this person, more is lost. So see the ratio. If you give him 10-fold proteins and the previous proteins, and it's all gone out, excreted out, then where is the protein? So it's called, here, it's also called protein losing enteropathy, especially in people with celiac disease, Crohn's disease, ulcerative colitis. So basically, what are these? Small intestine infections, large intestine infections, more diarrheal, irritable bowel syndrome can also happen like that if it is very bad. So anything which you are losing stool or passing out stool too much are these things. Autoimmune diseases, yes. Nephrotic syndrome, yes. You had I don't know whether you had a case. Third year had a case of nephrotic syndrome, all right, where the kidney function is actually suppressed. Now, I'm not going to go through all this. I have told you this, but what I'll do here is, okay, let's see. Why is it not working? Okay. What I am trying to tell you here is, which I have told you already, if a person has a SCID, if the person has a SCID, severe combined immunodeficiency, you give stem cells. Nothing else will work. Nothing else will work. And that you have to be very selective as a patient who is identical, patient who is HLA matched for the chromosome, for the genes, or the antigens on shorter arm of chromosome 6. Remember this in humans. They are the transplantation antigens. They are the antigens which can actually accept or reject a particular organ or stem cells. As I told you, you always check for antibodies, you always check for the T cell populations, lymphocytes, see if they are normal, look at the CD4, CD8 cells, which are helpers and the cytotoxic cells, and look at their populations, what is normal, what is abnormal. All right? These are some of the things. Lymphocyte function, I have told you, poke with mitogen, PHA, they have the same effect of actually inducing proliferation to see there the T cells are functional. Okay? Anything else? This is just for you to look at primary pathogens for T cells, all right? And clinical examples are SCID, D. Georges. This, as I said, is for your reading purposes, for your knowledge, okay? And I'll ask you very basic questions on this one. So I'm not going to pick out any of these as such as a point of this. You already know what it is. And anything, any questions you want to ask me now. Anyone? I know some are sleeping. They come to sleep, that's all. Hello? Any question? No? All clear? Understand now? Immunity you understand, and now you'll move to next phase of more clinical oriented part of the lectures, okay? So basically we are moving now away from the immune system, the immune responses, the different types of infections, specific, non-specific immunity, okay, active, passives, whatever it is. Now you'll move to a new frontier. So far, this, I'll not give it in your midterm. I've told you for me up to cytokines will be there. Cytokines? Tolerance? Cytokines? What was the last one? Aye? Yeah. I've given the blueprint, so that's what you use. Any question? No question? That means I have given you a lecture which you have understood, hopefully, inshallah. If not, there is a problem that will show in your midterm results. I don't want you to do bad in your midterm. I never expect my students to do bad results.